Dr. Rebecca Saunderson from Royal North Shore Hospital and Concentic. Is that correct, Rebecca? Concentic?
Yes, that's correct.
Okay. Rebecca's a dermatologist and a researcher with a passion for developing the healthcare system. And in this talk, I understand you're going to be discussing the development of e-consent videos, which can be used to circumvent long, complex PICFs by producing a video that has been co-designed, which is great because this really fits in very nicely with what Sonia was talking about earlier, and I think is going to fit in with our next talk very well too. Thanks very much, Rebecca.
Yeah, thank you. And hopefully I'll cover some of the other benefits of e-consent in clinical trials. So I first of all wanted to take you back to the year 1524. And here we can see the first consent form that has ever been identified. And this was an agreement between a surgeon and a citizen of the Ottoman state that that surgeon would extract bladder stones, and the citizen would pay 300 silver coins to the surgeon, and the citizen agreed that in the event of something going wrong, including death, that he would not litigate against that surgeon. This was all signed under Sharia law, and I'm sure you'll agree it's quite a robust consent process. But despite almost 500 years of many other technological advances and progress in medicine, consent seems to be an area that, if anything, it has gone backwards. So here we can see a participant and information consent form from a study of which I'm a principal investigator. It's no less than 17 pages long. And I would strongly argue that, as Sonia was alluding to, it does very little to convey information to patients in a way that they would understand the study well and understand the risks and benefits to be involved in the study. Now, we know that clinical trial consent processes are problematic. For patients, we also know that consent is a leading reason for poor recruitment into clinical trials. So there are two major reasons for poor recruitment. One is consent, and the other reason is that patients are not aware of the clinical trials. They have a very poor understanding of the consent forms, and for clinical trial organizations and research organizations, it's obviously hugely problematic because 90% of them fail to meet their recruitment deadlines. As has been covered, the forms are just way too complex, they're too long, they're too hard, they're too legal, they're repetitive, and it has been well established that consent can be one of the most stressful processes for a patient enrolling into a clinical trial. Also, what's hugely problematic is that the consent forms are often written in English, and therefore we're not recruiting from populations such as culturally and linguistically diverse background populations. And we know that 1 in 4 Australians are from or born overseas. So certainly we're recruiting a homogenous population, meaning that perhaps our results are not generalizable. So as I mentioned, most trials have poor recruitment, and 94% of clinical trials are delayed by at least 1 month. And this is really costly for a large organization running the trial, particularly for a multi-center trial. This can cost them anywhere between $600,000 to $8 million every day of delay. So it's a huge cost for the organizations running the trials. And obviously that's lost revenue opportunity for example, a pharmaceutical company or a medical devices company. But also we know, and certainly in New South Wales, there's been a huge push from government to try and support the attraction of clinical trials to the state, because it does provide a lot of employment opportunities. So if we're all clogged up because we can't recruit for clinical trials and we're not completing them, then obviously we're not going to attract clinical trials to be done in Australia from overseas. And probably one of the most significant results of a delay of a clinical trial or poor recruitment is a delay to getting those results, which might have an impact on society, which I will discuss in more detail later. So e-consent, I don't think is just about converting a paper-based form into an electronic document, because all that's going to serve is to replicate the deficiencies that we already have in our current processes. By uploading a complex form onto an electronic platform, we're not really solving the problems of e-consent. So what really e-consent should do is using electronic and multimedia to ensure that the consent is simple, understandable, and accessible. And I really want to emphasize that it's very important that it's not meant to replace a discussion between a study participant and site staff. It should be something that augments the process. Now, when we look at the medical literature, all evidence supports audiovisual media. So there's more than 200 publications in the literature showing that video consent is superior. It leads to much better patient understanding, much better patient satisfaction. There can be time savings, and obviously, particularly in pandemic times, e-consent enables consent to be undertaken remotely. So what our consent platform does is we have customized consent to animations. I will also show you an example shortly, followed by interactive checklists that help to confirm the patient has understood the risks and benefits of participating in the trial, followed by them signing electronically, which is converted into a PDF, which can be stored in their record. We also understand that one size does not fit all, and it's not appropriate to have an animation or a video for every single trial. So we also do customize, simple to understand consent forms that can be emailed to study participants, followed by the same interactive checklist, and that's converted to a secure electronic form. Now, some people seem to be a little bit frightened of e-consent, so I just thought I would very quickly go through the way that it works. Essentially, a patient who's interested in the research will express interest in the study, and if they meet the inclusion criteria, then they can be emailed or SMS'd their e-consent. They can watch the animation or read the form, answer the questions, clarify any questions that they might have about the study before signing, and then they can be enrolled into the study. So it's a very simple process and is not something that we need to be fearful of. This is just a screenshot of one of the animations that we did for a study at Epworth Hospital. And I was just going to show you part of an animation that is going live shortly.
You have been invited to take part in a research study called the iSearch study, which stands for the intrapartum sildenafil for safely averting the risks of contraction-induced hypoxia in labour study. This study is being undertaken by the NHREC Clinical Trials Centre, University of Sydney, and the Mater Research Institute at the University of Queensland. This video will outline the important things that you need to know before deciding whether or not you would like to take part in the study. Thanks to previous research, having a baby today is safer than ever before. This study is being done to find out if sildenafil, a medicine commonly known as Viagra, can make childbirth even safer. Sometimes during childbirth, your baby may experience fetal distress. This is when your baby becomes unwell because they are not receiving enough oxygen through the placenta. Sometimes the contractions can squeeze the blood vessels in the placenta, which can reduce or stop the oxygen supply to your baby. This causes fetal distress. When this happens, there can be serious consequences, including a brain injury, a stillbirth, or death of the baby following birth. To prevent this from happening, if your baby has fetal distress, they may be urgently delivered by vacuum, forceps, or an emergency cesarean section. This can have impacts on both mother and baby. Sildenafil is a medicine which opens up blood vessels and has been used for more than 20 years to treat medical conditions in men, women, and babies. In an earlier study, we gave women in labour up to 3 doses of sildenafil. It reduced the number of women having emergency delivery by forceps, vacuum, and cesarean section for fetal distress and was safe. The iSearch study aims to find out if sildenafil will improve the baby's condition at birth. We will also find out if it reduces the need for forceps, vacuum, or cesarean delivery for fetal distress. The companies which make sildenafil have no role in running this study or reporting its results. If you agree to take part in this study, you will be placed into one of 2 study groups. The first group will be given the medicine sildenafil from the start of labour and then every 8 hours until birth. The second group will be given a placebo or inactive medicine, which looks exactly the same, also at the start of labour and then every 8 hours until birth. Both groups will have a maximum of 3 doses. You will have an equal chance of being in Group 1 or Group 2, and neither you nor your medical team will know which group you are in. In addition to receiving either the medicine, sildenafil, or the placebo, you will also be monitored throughout your labour using fetal heart rate monitoring, or CTG. After your baby is born and the umbilical cord has been cut, your medical team will take a small sample of blood from the umbilical cord to test its pH. This is a routine test after birth, and you can still have delayed cord clamping if you wish. If you are giving birth in a Queensland hospital, you can also choose to have blood tests to check hormones that measure how well the placenta works, which can tell the researchers who is at a higher risk of getting fetal distress. Have an ultrasound scan before and after you have the first tablet, which takes about 20 minutes and measures your baby's size and the blood flow from the placenta to your baby. Both of these tests are for research only, and if you have these tests, you will not be told the results. The blood samples will be stored for future research. However, if the ultrasound result shows that your baby needs treatment, then your medical team will be told the results and these will be acted upon. It is important to note that if you choose to take part in the study, you will receive the same care as those who decide not to take part in the study. You will be able to breastfeed your baby as normal. Our study team will contact you about 1 month following discharge from hospital to check that you and your baby are well, and if you agree, a study midwife will contact you every 6 months for 3 years to check that your contact details are correct. When your child is 2 years old, the study team will ask you questions about their development, such as speaking, movement, play, and social development.
In the interest of time, I'll continue, but we just had a couple of minutes left. Following the participant watching the animation, they answer questions and agree to the risks of the study before signing, and then that is converted into a PDF form. That's emailed to the site, and it's also emailed to the patient as well, or participant, so they can watch that with their friends and their family as many times as they would like to. In terms of validating video consent, we undertook a study at Royal North Shore Hospital for a dermatology procedure known as Mohs micrographic surgery. This was a randomized controlled trial, and patients were randomized either to have their animation or to have their doctors explain the consent and procedure to them. What we found is that the animation significantly improved the patient understanding, particularly of the risks. It saved the doctor's time, and 4 out of 5 patients preferred the video to their doctor's explanation. We have also looked at enrolment and e-consent. So this was undertaken at Epworth Hospital, and e-consent was implemented in 2020, which was obviously pandemic times, for an orthopedic study looking at recovery and rehabilitation in orthopedic surgery. It was called still undergoing recruitment. But we basically were able to compare the traditional consent methods versus using e-consent. We found that age was not a barrier to using e-consent, which is often a concern. All of the patients in that study were 60 years or older, which is not very old in today's standards. We found that there was a 94% decrease in the time to complete a consent and enroll a patient into the study when the e-consent was used. And also what we found is that the staff time savings in a clinical trial setting were substantial, more than 2 hours per participant. So we've concluded that it can lead to faster enrolment of patients, especially during pandemic settings. These slides have been adapted kindly from Professor William Tarno Mordy, who was involved in doing an e-consent study as well at Epworth Freemasons Hospital. and they implemented consent, you can see here, in December 2020, which was pandemic times. And what they found actually is that it hugely improves the recruitment into the study. So we do think that e-consent can lead to faster recruitment of patients into clinical trials, particularly in the setting of a pandemic. Now, if we, again, these were adopted from his Professor William Tano Mordi, slides with permission, but this was a study that they did, and it received an award in 2018 for the ACTA Trial of the Year, and it looked at delayed versus immediate cord clamping in preterm infants. So more than 1,500 infants were recruited into the study, and basically what they found was that the relative risk of death or disability at 2 years was substantially reduced. So I guess the significance of this is that there's more than 1 million babies born less than 30 weeks gestation annually worldwide. So applying this evidence could mean 500,000 extra lives without disability in the next decade. So if this study had been completed in 5 years instead of 10, then essentially 1,000 more deaths and disabilities would have been prevented. So, and we all know that the clinical trial recruitment is 94% of them fail to meet the recruitment deadline, so it's often delayed. So this was the actual recruitment here compared to the expected recruitment. So essentially, if we can recruit to clinical trials faster, if we can get the results out faster, then we can really have a huge impact on society. And that's something that's been highly relevant during the COVID-19 pandemic. In terms of diversity, that's something that is very important to us, and we're undertaking a study at the moment at the Royal Brisbane and Women's Hospital looking at renal biopsy consent, and we're actually translating the animations into multiple different languages. So we think that this will be the first national study looking at this, and certainly it well may be the first international study where we'll have animations in the top languages that patients can essentially be consented in their own language. So benefits of e-consent, essentially better engagement and comprehension for patients, improved enrolment, improved recruitment, significant time savings, and obviously we can adjust the content to culturally and linguistically diverse populations.
Time, I'm afraid.
Beg your pardon?
You're actually way over.
Oh, am I? Oh,
yes.
Okay, no problem. Look, and I'll just quickly highlight this for a phase 3 clinical trial. If we're saving 2 hours per patient for consent, that equates to more than $300,000 of staff time savings, which is really huge. And having e-consent means that there's less deviations for consent, which is often problematic for sites when they have audits. So I'll leave it at that. And I'll just say we're very happy we got nominated, or we're a finalist for the 2022 Telstra Best of Business Awards in Championing Health. Thank you.
Well done.
Thank you.